everybody come in, close the doors, we can get started. Our next speaker, we're happy that is back with us again, spoke to us a few years ago. Dr. Bohannon's clinical associate professor at UCSF, San Francisco, director of clinical research, has been in private solo practice for about 36 years, 40 years, 38 years. 38 years and over 80 publications, and extensively researched and published, especially on the metabolic syndrome. So we're happy on something that, as you can see from the previous lectures, something that we truly need to address vigorously. All right, Nancy, it's all yours.
Thank you. Thank you, Dr. Khan. Thank you for inviting me back. I love this group. It's really great. Dr. Kopecky actually gave a lot of my talk already, so this is good. A lot of this may seem a little bit redundant. I was very busy during his slide hiding a lot of my slides, so it wasn't completely redundant. So until yesterday afternoon, I was still making more slides. Last night, when I found out that I had less time than I thought, I started hiding slides. I hid slides until 2 a.m., and then this morning, I hid more slides. So actually, my talk is less than it was, but it's still too much. So I think we'd better get started. Okay, so I just was going to go over, this is the official definition of obesity according to the American Society of Bariatric Physicians. And obesity is defined, I think this is a pretty good one, chronic, relapsing, and unfortunately you're going to see relapsing is a real problem, a multifactorial neurobehavioral disease where an increase in body fat promotes adipose tissue dysfunction, and we're going to talk about adipose tissue fat. Is this going in and out? It sounds to me like it's going in and out. Is it all right now? Okay. It promotes adipose tissue dysfunction. We're going to talk about endocrine hormones being made by fat. Fat is an endocrine and cytokine making factory, and that really promotes not only dysfunction in the fat, but it also promotes atherosclerosis, insulin resistance, and a lot of other things. And also there's the abnormal fat mass physical forces that is contributing to arthritis and other metabolic, biomechanical, and psychosocial adverse consequences. So it's really a multifactorial disease, and the healthcare costs are absolutely staggering at $190 billion a year in the United States, and that's responsible for almost 21% of the annual medical spending in the United States. And it's getting worse, as you know. One of the things is, we're so used to seeing people who are overweight and obese that we forget what normal is. We really do. 1/3 of adults in the United States are overweight, and 1/3 of adults in the United States are obese. And as Dr. Kopecky said, the fastest growing segment are the severely, morbidly obese, which means that we've only got 1/3 of people who are normal weight. So 2/3 of people are either overweight or obese. You start thinking of normal as being overweight, because that's sort of the average, but average is not normal. And when they gave a survey to parents of clearly obese children, and it was a sort of a multiple question thing, and they asked, how is your child's weight? 75% of those with obviously obese children said about right. That was the box they checked, about right. Their weight was about right. So if they're not recognizing it, that's a problem. We're going to talk a little about pediatric obesity too. And of course, this is California, so we've really got to talk a lot about racial and ethnic disparities. This is something we should always think about. In the United States, we're a melting pot, and is your patient Hmong or is your patient Miwok, Native American? This is always important. We've got to keep the social and cultural. I mean, trying to get Samoans to get down to a BMI of 25 is often not very realistic, but we have to keep those things in mind. And there are racial and ethnic disparities in diabetes, coronary artery disease, cancer, stroke, all of these, and we need to be culturally responsive to that. Now, you've already seen these things. You've seen even more recent ones. Mine only goes up to 2000, but what I wanted to show you is really both in men and women. We were going along just fine with about 15%, either between 10 and 15% of people being obese until the 1976 to 1980 inflection point where obesity then just sort of took off, and it's continued to be linear. And this is really a problem. Maybe 6 months ago or something, there was a report that said, the obesity is leveling off. We're not continuing on this upward trajectory. But then a few months later, the next count showed that upward trajectory, unfortunately, was continuing. And this is just going to show you from 1994 is where we started. This is obesity, prevalence of obesity. This is diabetes. Anyway, the darker it is, the worse it is. And you can see that there's increasing obesity, and as there's increasing obesity, there's increasing diabetes, and it just keeps continuing and continuing and continuing. And these are the states with BMIs here, average BMIs over 30. You can see it's just getting terrible. If we look at 94, 2000, 2010, here we are, 26 that was. So you can see these are states whose average adult BMI is over 26, so they're obese. Actually, these 25.9s are obese too, but you can see increasing obesity throughout the country, and it doesn't look like it's stopping. Now, some interesting obesity facts, and we don't have the automated system, and I don't want people to try and put up hands because they'll be embarrassed if they don't do it right. But in your mind, I've got quite a few of these questions. In your mind, see what you think. What's the proportion of deaths associated with excess weight in the United States? And it is 1 in 5. So 20% of the deaths in the United States are related to excess weight. Obesity is associated with various comorbidities, type 2 diabetes, CV disease, cancer. What proportion in the world of cases of type 2 diabetes are attributed to obesity? This is in the world. And while you're thinking about that, China and India are really undergoing a huge epidemic right now of diabetes. And so this is going to, considering the immense populations, this is going to contribute even more. So about 50% in the world currently are attributable to obesity. Now, here we are, culturally sensitive once again. The ethnic groups that have the greatest risk of obesity, and there are certainly genetic factors, so certainly there's also societal factors, and when people move from one place to another, they tend to take on those habits. So here the answer is Black, Latino, white, and Asian. Okay. Which of the countries has the highest obesity rate among adults? Those of you who've heard me before probably are going to be able to get this. I used to consult on a regular basis in this part of the country years ago, and it is Saudi Arabia. The highest obesity rate among these, and actually for a region is really the highest. And this has happened, interestingly, this has happened in the last, now I guess it's probably 60 years. And it's become a huge problem, a huge problem. They don't have the enormous population, but for those countries, it's a big problem as far as health goes. There's certainly genetic influences, the kinds of genes that allowed the people in the Middle East to trek across and be nomads and trek across large stretches of desert with their camels from oasis to oasis. Once they got oil and got fed, suddenly the obesity, which they had never seen before, became a real problem. Okay, over the last 30 years, obesity has been increasing worldwide. In which of these countries managed to lower its obesity prevalence in 2013? And you probably know that. None of them. Okay. According to the World Health Organization, actually governments could, and we saw from Dr. Kopecki's slide, we saw what you can do, like in Japan, and I love the Moscow subway squats. Oh my gosh! I mean, that's something you'd have to work up to. You don't just go and do 30 squats on the first ride on the subway, but. According to the World Health Organization, governments could reverse the obesity epidemic if they introduce more regulation on fast foods and soda. And we've tried to do that here in California in various places, and I think Berkeley passed it. It did fail in San Francisco, but I tried to tax sodas. Okay, you can boo me if you want, but I tried to tax sodas. Which of these countries has actually enacted, a country, not a county, which of these countries has actually enacted a tax on soda to combat obesity? Choose all that apply. Okay, you got it in your mind? You know what you're going to answer? Okay, yeah, I guess most of you people, okay, France. What about Mexico? 2013, Mexico enacted a tax on soda to combat growing obesity there. Now, I was doing this at 2:30 this morning. Okay, look at these, and these are the kinds of things that people are we use for anorexia nervosa or whatever to get perception, body perception. Okay, I would put myself probably somewhere between here and here, but I know what my BMI is. Okay, so where would you put yourself on this? Okay, and what do you think is normal? All right, who's saying anorexia here? Anybody? Okay. All right. Well, you're right. It's not anorexia. It's normal. But we've forgotten what normal looks like. That's overweight. And I know I'm not overweight. My BMI is down there. But that's obese. This is severely obese. And this is morbidly obese. But I think most Americans are somewhere around in here. Certainly my patients are more in here. If I have a type 2 diabetic patient come in with a BMI of 27, they look downright skinny compared to the rest of my patients. Okay, I admit this is photoshopped. He doesn't really have those tattoos. But there is such a big association, a strong association in both women and men, next slide, between diabetes. And you can see that from a BMI of less than 21 to a BMI of 25, there is a six-fold, and this is, say 24.9, just before you start being overweight, six-fold increase in the risk for diabetes. And with men, it's the same, but it's a little at a higher rate. The inflection point is about 27 for really taking off, but it starts taking off at 22. When we look at Hispanics, it's different for the inflection point. And the optimal BMI cutoff for predicting diabetes in Mexican American men is 27.8 versus 29.5 in non-Hispanic white men. Now, demographically, non-Hispanic white men are the most insulin sensitive people on the planet. So demographically, if you're a white man, you're much more insulin sensitive and less insulin resistant. Does that mean we don't have any white men who have diabetes? No, they just have to be fatter than other men and more inactive than other men and have other risk factors. But the men really sort of demographically, genetically, whatever, are more insulin sensitive than most other people. Okay, abdominal obesity is really associated with diabetes. And you can see this, and this is for a waist. Now this one is for, this is the women, oh, like that chopped off. Okay, so relative risk, this is for women. This is the Nurses' Health Study. This is 42,500 women, okay? So waist circumference less than 27.9. If that's 1, then as the waist circumference increases, you have increasing risk. So if the waist circumference is greater than 38 inches, you've got 24 times the risk for diabetes than if you're there. Now, I would say I'm probably about here, but that even that is a little bit more. But I would say an awful lot of our patients are in the 32 to maybe 36 range. And you can see that is at about 10 to 12%, 10 to 12 times the risk for developing diabetes. And if you look at waist circumference tertiles and then look at the number of cardiometabolic risk factors, blood pressure, triglycerides, LDL, HDL, glucose, BMI, you can see that no matter how many risk factors you have, if you have a large waist circumference, that increases your odds ratio for developing diabetes. Now, how things have changed. This is Big Joe, the largest man in the world in 1903. And this is maybe not a typical, but not a terribly atypical, especially in the South, policeman in 2012. Rather shocking. We have, again, gotten so used to seeing it on the streets. And our children. Our children. We've got to stop childhood obesity. Look at this. These are the trends for children and adolescents. And again, 1976 to 1980, suddenly huge increase. Currently, this ends at 2000, but right now, the latest one for children is around 17%. So we've gone from 4 to 5% obesity in the 1960s to 17% obesity currently. So, and again, that is continuing to increase. The advent of computers and more and more television time, playing with the iPod or the iPad rather than going out and playing on the streets or in the parks, all is contributing, of course. This was childhood obesity in 1971. This was a boy who was used to demonstrate childhood obesity. This is our obese kid now. 1 in 4, and I bring this up because here he is eating some fast food. 1 in 4 Americans consume fast food on a daily basis, and that's a real problem. I'm totally against graffiti. I hate graffiti, but actually this is the only graffiti I've ever seen that I really love. And I don't know who did that, but that was very clever on the billboard. That's the way it should be. Now, what we're seeing here, we're getting mixed messages, and somehow, usually it's the fast food companies have more money to do the advertising than do our healthcare organizations. Sedentary lifestyle, of course, you've already heard about that, the importance of exercise. The more exercise you do, the better, as long as you don't hurt yourself. I do not recommend that heavy people jog or do that kind of traumatic exercise. Walking is fine. You don't want to hurt your knees and hips. So when you're jogging, especially if you jog like that, if you're not used to doing it, you really tremendously increase the forces on your knees, and you So bicycling or walking, things like that are much better. Interval exercise, as we heard from Dr. Kopecky, is really, really great. And I think the way he said it was very motivational. This was a television viewing study from Australia. Viewing time was associated with increased risk of all-cause and CVD mortality. And our kids are spending a lot more time. This was in adults, but our kids are also spending a lot more time in front of screens, one kind of screen or another. And the latest thing that just came out in the last 2 weeks was that more than 1 hour of television time per day in kids greatly increases their risk of cardiovascular risk, more than 1 hour. And the Academy of Pediatrics, I think it was the Academy of Pediatrics said no more than 2 to 3 hours of television time. Well, this new study shows 1 hour should be the maximum amount of television time per day. So a 4-step escalator? Come on, you gotta be kidding me. I can't tell you how motivational these things are. Who here has some kind of Fitbit or something like that? Yeah. Oh my gosh, I'm surprised it's so few. Oh, these are so motivational. I mean, you look at it, you say, oh, at the end of the day, I have a very small office. At the end of the day, I can do 2,000 steps a day if I just go to the office. So at the end of the day, you look at it, oh my God. So you go out and you walk the dog for an hour, or you climb up and down the stairs. You do something because you just can't bear to go to bed with such a low step count, right? Yeah, everybody who's got one says the same thing. Okay, it's not just people who don't move and get fat. That's true of animals as well. Even elder adults can realize great benefits of exercise. And fitness, we talk about exercise, we talk about aerobic exercise and anaerobic exercise, but fitness is more than just exercise. Fitness has 5 components, and I always forget one. I'll see how many I can remember now. Okay, so we've got endurance, and we've got power, and we've got flexibility. I'm forgetting 2 now. Endurance, come on, help me. Endurance, power, flexibility. I've forgotten it. Okay. I'll remember it later. Yeah, okay. So, sleep. I wanted to get this in because this is a new thing in obesity that we're talking about a lot. If you don't get enough sleep, it actually changes your metabolism. It changes your brain. And the Centers for Disease Control say that 35% of people, more than 35% of people in the United States are sleep deprived. And we are not, as a country, we are not getting enough sleep. And that actually does influence the way our brain functions. That's me getting a sleep study. And this stuff is not hair. Those are all wires going into my head. And sleep apnea is grossly underdiagnosed. Now, when you're a very obese, diabetic, hypertensive person comes in and you ask if they snore and they snore, then of course you're going to get a sleep study. But they don't have to snore to have sleep apnea. And they don't have to be obese. And maybe they're obese and hypertensive and diabetic because they have sleep apnea. And you can have anatomic sleep apnea. Do I look like I have sleep apnea? I have sleep apnea. I found out sort of incidentally because I was having trouble sleeping. I went and she said, it's a sleep center. We got to do a sleep study. I did a sleep study. I've got an anatomical sleep apnea. What should be 2.4 centimeters is 1.6 centimeters. And when I lie down, it closes off. So, but we know from forward-looking studies that sleep apnea contributes to obesity, hypertension, and diabetes. And how does this do it? Well, just think about it. If intermittently you're getting hypooxygenated, that puts out stress hormones, epinephrine, all of these things that then contribute to insulin resistance, and the and also contribute to hypertension if you're having little baby shots of epinephrine all through the night. contributes to hypertension, and the insulin resistance and contributes to obesity. It contributes to a decreased recognition of satiation in the brain. If you look at people who are insulin resistant versus people who are not insulin resistant, who are the same weight, the ones who are insulin resistant don't feel full on even when their insulin levels are even higher because they're insulin resistant. They're more likely to gain weight. Anyway, so remember that. Intra-abdominal fat, we were talking about BMI, that's high-risk fat. Visceral fat is not just a storehouse for triglycerides. We've got these fat cells, they're chock full of triglycerides. That's where your fat is supposed to be, is in your fat cells. But if those fat cells get too full of fat, they become inflamed. And when they become inflamed, they call in inflammatory lymphocytes, which then put out more cytokines, which then stimulate the fat cells to put out cytokines that are inflammatory cytokines that then cause inflammation of the endothelium, the lining of all the blood vessels, which then contributes to atherosclerosis. The fat, the visceral fat, makes a whole lot of substances, and some of them are good substances and some of them are bad substances. We've got autocrine ones, autocrine and paracrine, and then we've got the endocrine ones. Leptin, which has to do with appetite, adiponectin, which also has to do with appetite, pi1, which increases coagulability, so they're more likely to clot, even if their blood vessels are wide open, they're more likely to clot and cause an infarction. All of these things, tumor necrosis factor alpha, interleukin 6, these are powerful cytokines, powerful inflammatory cytokines. Now, this doesn't show very well, but oh, just a minute, I should do it this way. I'll outline this. Okay. It shows up really well here. It's too bad it doesn't show up there. Okay, so this here is, that's hard to do. That is a fat cell, okay? Whoops, okay. Didn't mean to do that. Go back. Just scroll, okay? It's not scrolling.
Previous.
There we go, okay. So that was a fat cell in a normal person. Here is a lean person. And here, oh, come on. Here, there we go. There's a fat cell in an obese subject. So when you get fat, you store more fat in. But when you do that, it calls in these inflammatory cells. Those are macrophages. And there's no macrophages over here. The little black dots here are cell nuclei. But these are inflammatory macrophages. And so that increased infiltration of macrophages causes increased inflammation and makes everything worse. Now, when you're storing fat, when you run out of fat cell storage space, and I explained this to one of my patients, a lovely lady, normal intelligence, but only second grade education. And I was trying to explain it to her. She was a very, very Christian lady. And I was trying to explain about her diabetes and things, and that it was important to lose weight and to exercise. And I was trying to think of a way to do it. And I said, okay, well, your fat cells are like this, and God made the fat cells to store fat. So the fat cells start storing fat, and they get to a point where they just can't stretch anymore. They're like a balloon. If they stretch anymore, they'll pop. And God doesn't want you to pop your fat cells. Have you ever seen anyone, take one more bite and suddenly their fat just goes and explodes? So you wouldn't explode. God made it so that the fat can go other places when it runs out of room in the fat cells. So it goes into your muscles and into your liver and other places. And actually that's what happens. But she comprehended that, and she got really good about her diet and exercise. So we know that it goes in the liver, and we know that diabetics tend to have fatty livers. The type 2 overweight diabetics tend to have fatty livers. Fatty liver disease, non-alcoholic fatty liver disease, has taken over as the number one cause for liver transplants now and liver failure over the hepatitis. Yeah, it's really becoming rampant. As a matter of fact, we've got a guy at our hospital who's doing a lot of fatty liver disease research, and you can see it, when you're scanning and things. But when the liver is getting full of fat, the muscles are also getting full of fat, and when the muscles get full of fat, they don't work well, and that makes sense. So here we have, and we forget that when we're talking about muscle, the heart is a muscle. Okay, so here is a person who is overweight. This is a cardiac muscle biopsy, and these are the muscles, and this is sort of what they should look like. These are both stained with oil red O, so that fat stains red. And you see there shouldn't be any fat in a heart. I mean, if you get chickens and you're getting or turkeys and you get the heart, there's no fat in the heart. When you get a turkey and you're looking at the stuff. When this person is 42 BMI, look at all the fat in the heart muscle. Well, you can imagine it's sort of like, if I'm a heart muscle and I'm supposed to be contracting, so I contract, Okay. All right. Now, if I've got a big belly, which is what, oops. Okay, if I've got a big belly and I'm a heart muscle, I'm trying to contract, I go, because you can't get over your belly. I know what that's like. I've been pregnant. All that heart muscle is not, that fat in the heart muscle is not a good thing. So losing weight really helps. A 5% weight loss will help the hemoglobin A1. Whoops. Where'd I go? Okay. Yeah, I knew I felt like Madonna. Okay, so 5% weight loss, we get really good decrease in hemoglobin A1C, blood pressure, total cholesterol. With 10% weight loss, we can do even better and also get some reduction in triglycerides, which our National Lipid Association is all for. Are you aware that 4 of the 5 leading causes of death in the United States are associated with obesity? Everything except chronic lung disease. Everyone knows they tend to get skinny. But heart disease, cancer, cerebrovascular disease, diabetes are all associated with obesity. Now, which of these cancer types is associated with obesity? We could put breast and colon. We could put a whole bunch, even multiple myeloma, but all of the above. I mean, these are some of the weird ones. If I put breast or colon, you'd all know the answer. Okay, the diabetes. So what happens if you can diet and exercise, which is what Dr. Kopecky was talking about, and we all know diet and exercise, if you do it, it works. No question, if you do it, it works. You decrease your calories, and you burn more calories, it's going to work. So this was 3,234 patients, BMI 34, so they were obese but not morbidly obese, and they had impaired glucose tolerance. They were on a 4-year trial, were given either just placebo or active metformin or active lifestyle intervention for 4 years. And what happened as far as developing diabetes, they started off with impaired glucose tolerance. And compared to those who got placebo, there was a 31% reduction in the development in people who got just metformin. They kept on with their usual life and only got metformin, 31% reduction. We are not using enough metformin in people who have prediabetes. We need to have primordial prevention. You're not going to see a study on it because it's been generic forever. So it works. We know that it works, even just adding that without lifestyle. But when you did lifestyle, without the metformin, lifestyle lost 7% of their body weight, had a 58% reduction in the development of, or the progression to type 2 diabetes. So we know that works, and there's no reason why you can't do lifestyle and metformin together. The Finnish diabetes prevention study showed exactly the same thing. This is with lifestyle over a longer period, an 8-year period, and there was a 43% reduction in lifestyle intervention in the development of diabetes from prediabetes. The Look Ahead study was a huge disappointment. Huge. Over 5,000 subjects, usual care, which was diabetes support and education, or usual care plus intensive lifestyle intervention. It was going to last 13.5 years with 4 years of intensive lifestyle intervention to achieve 7% weight loss. And the primary outcome was cardiovascular. After a few years, it was going to be fatal MI, stroke, non-fatal MI, and stroke. After a few years, they weren't seeing any difference. There were far fewer events than they expected. And that's probably because they were getting statins and ACEs and all these sorts of things. So then they added hospitalization for angina as one of the primary outcomes. And you can see that at 1 year, those who were intensive lifestyle intervention had lost 8.6% of their weight and had statistically significant improvements in all of these cardiovascular risk factors except for LDL. That was not different. At 1 year, you can see compared to diabetes support and education, those with intensive lifestyle did much better in weight loss. And actually, well over a third, 37.7%, lost 10% or more of their body weight in the first year. Unfortunately, despite continuing intensive lifestyle treatment, they tended to gain it back by 4 years. They weren't back to where they started, but they tended to gain it back. At 1 year, they had their best results. And after a median follow-up of 9.6 years, the trial was stopped because of the results of a futility analysis. It was determined that based on what had happened so far, they were not getting a reduction in cardiovascular endpoints, despite the 4 years of intensive lifestyle intervention. So again, these were people who had diabetes. We need to do primordial prevention. We don't wait until they develop hypertension and treat the hypertension. Wait till they develop diabetes and treat the diabetes. Wait till they develop obesity. We want to prevent all of these. And obesity really is becoming much more of a global threat than many other things as far as health goes. Okay, so if an obese person with a BMI of 32 with hypertension and diabetes has been unsuccessful in getting 5% weight reduction after 6 months of lifestyle modification, then what should be the next step? And hopefully, I think at this point we need to consider pharmacotherapy. For a BMI of 32, 6 months is plenty of time. As you saw with the Look Ahead, with intensive lifestyle intervention, they got the most weight loss at 1 year. And they were doing very well, but then they tended to gain back. So if they're not losing the weight, we need to consider pharmacotherapy. And now we have a lot of weight loss drugs that are indicated for long-term treatment, not just for 6 weeks or 6 months, but for long-term treatment. We need to start looking at obesity as a disease like hypertension or diabetes or dyslipidemia. You don't take statins for 6 months. You don't take DPP-4 inhibitors for 6 months. You don't take your ACE inhibitor for 6 months. It's for the rest of your life. Or as I tell my patients, it's for the rest of your life until something better comes along. But obesity is a chronic disease. And if the person is being treated and hasn't lost at least 5% of their body weight in 3 months, on the medication with, of course, lifestyle intervention at the same time, then stop that medication, because if it hasn't happened 5%, it's not going to happen with that medication. So it's time to maybe try a different medication. And these medications all work in different ways. Some of them work just by blocking fat absorption. Some of them work on the appetite center. Some of them decrease cravings. A lot of people, do fine on their diet all day, and then 11 o'clock at night, They make up for 2,000 calories. Surgery, this is not the kind of surgery you need. This is liposuction off the flank and into the tank. This is not going to do anything for your metabolism. As a matter of fact, it might make your metabolism worse because you have fewer fat cells into which to put the fat. So what the kinds of surgical interventions would be bariatric surgeries. And the kinds of bariatric surgeries that we have now that are pretty popular, the lat band is really losing its popularity because of the recidivism. I mean, it's sort of like a more complicated lifestyle intervention in that they lose weight right away and then slowly they gain it back, and they're often very uncomfortable because you're just forcing their stomach, or their little stomach pouch, to get full real fast, and they may have a lot of indigestion, a lot of regurgitation. They're still hungry, but they can't eat anymore because their stomach won't hold it, and it gets stretched out, and they tighten the band some more, and then it's not long-term successful for most people. So the surgeries that are being done now are the vertical sleeve gastrectomy, where you remove most of the stomach. And so all you've got is this little bit of stomach right there. But it's not doing the same thing as the pouch, although it is greatly reducing the volume capacity. It's not doing the same thing as the lat band because you're removing the part of the stomach, or a large part of the stomach, that's making the hormones such as ghrelin, which cause hunger. It's removing a lot of the endocrine and the signaling part of the stomach. And so these people, unlike these lat band people, aren't getting hungry, and they're satisfied with smaller amounts of food. Of course, it's a much more invasive surgery. And then the one that's had a lot of popularity for many years is the Roux-en-Y gastric bypass, and this is the one where you don't remove anything, you just change the plumbing. You cut most of the stomach, you leave the stomach, but in the belly, but you remove it, most of the stomach, from being passed through with food. You make a gastric pouch, and you connect that to a lower part, to the jejunum, to what is now left of your stomach. Meanwhile, the bulk of your stomach, with its hormones and everything, and the duodenum, is bypassed back into the jejunum. Now, that's the one that has long-term had the best outcomes. And when we look at the POSH trial, which was using that, it took 16 years to actually show it. But after 16 years, there was a statistically significant difference in cumulative mortality. Mortality is a hard endpoint, especially now that everybody, I guess this is a good thing, now that everybody's being treated with statins and antihypertensives, and you can really control diabetes now. I mean, you can get those A1Cs less than 6.5 long term with all of our new drugs. So there should be fewer cardiovascular endpoints, which means you need more people to do the study, and it has to be longer. But treating obesity chronically by getting weight loss and then maintaining most of that weight loss, and this kind of surgery, people will lose about, on average, 50% of their excess weight. So if I should weigh 120 and I weigh 220, I'll lose about 50 pounds. I will still not look as good as I'd like to look, but 50% of the excess weight in general is maintained off. They'll lose more and then they'll gain a little bit back, but they'll still be quite a bit under where they were. And in the long term, it does decrease mortality. But we know how well lifestyle works if you do it, but we know how people tend not to stick with it. So overall, obesity is a multifactorial disease. Environment is playing a huge part. Environment's playing a huge part. Life is so easy now. Back in the old days, when you scrubbed your clothes, or even my mom in the washing machine, cranking to wring it instead of having an automatic wringer, and then carrying all those wet sheets out, hanging them on the line. people didn't used to talk about exercise. They didn't have time to exercise. They were too busy living and doing exercise. My little petite blonde blue-eyed mom slinging around these big cast iron skillets. You could never talk to her about exercise. Now, life is so easy. We have to carve out time to go to a gym and exercise and do Stairmasters and things. So I'm going to ask for questions if we have time, but what I thought we really need is, why are we not funding this? And I'll leave you with that thought.
All right, I love your passion. Questions?
Yeah, I have a question. When you have obesity in children, as they're growing, especially in girls, it produces excess estrogen.
Mm-hmm.
Are there any studies at all, because I haven't found any, that show a correlation between, we know that there's incidence of infertility with obesity in women. Are there any correlations between when obesity occurs, whether it's prepubescent, and those excess estrogens are interfering with the sexual reproductive estrogens through puberty?
A really good question. I can't say that I know the answer to it. The question was, we know that the kids are getting fatter. As the girls get fatter, puberty occurs earlier and earlier and earlier. And unfortunately, when they go through puberty, they also stop exercising. I mean, that's one thing. They become very body conscious, and if you look at exercising and participating in sports and things, it really falls off after puberty. And what is the correlation between that and PCOS or fertility problems? I would guess, but I don't know of any studies looking at the time of development of obesity and later infertility issues, but I would guess that via PCOS type actions that there would be a correlation, but I don't know of any studies showing that.
I was obese from a young child, and I had the Roux-en-Y 11 years ago.
Oh, you did? Oh, well, she's announcing you had Roux-en-Y. You look fantastic. So how much, if you don't mind me asking, what was your percent body weight loss?
I was 353 at the time of my surgery.
353.
Lost about 180
Lost 180 pounds?
pounds. I got down to about 160. So I tell people now, I'm half the woman I used to be, but I'm twice as good at it.
Half the woman she used to be, but twice as good at it as it had it. Wonderful.
That's great.
I was told from the time that I was like 11, 12 years old that I would never have children, ever, my entire life. That if I ever got pregnant, I would self-terminate before 8 weeks. That if I went beyond that, it would endanger my life as well as the child's life. At the age of 38 years old, many years after my surgery, 5 years after my surgery, I got pregnant and have a beautiful 7-year-old daughter now.
Has a beautiful 7-year-old daughter now after having been told right from the beginning she would never carry a pregnancy.
So that's where in going through nursing school, this was always one of my big interests, is finding out, because I was obese from a very young child, from about the age of 5.
From the age of 5, obese. So there's something there going on. Yeah.
Because I know people that were heavier than me that had 3 or 4 kids.
Yeah.
They didn't get obese until their 20s.
Okay, it sounds to me like you need to talk to an active obesity researcher at a big pediatric area and see if that that correlation can be made, because probably nowadays with data banks, the information is probably there. It just needs to be mined and pulled out.
Question? Andy?
Oh, there's one.
Andy?
I was going to ask, I'm into practicing preventive development on all my patients, and I always get the question from my patients, like, isn't gardening enough? They always tell me they're doing household chores. I'm vacuuming every day. I don't really know what to tell them except to tell them to huff and puff for 30 minutes a day.
Okay, gardening is actually counted as an exercise. Being a bit of a gardener myself, I don't know how much I agree with that. It depends. One thing, if my husband does the pickaxe in the clay, now that's exercise, and then I go in and just put in the little plant, and I don't think that's the exercise. So it sort of depends on what kind of gardening you're talking about, and you've got to be honest with yourself. I would say that they need to add things to what they do every day. So if they want to improve their fitness, improve their endurance, improve their cardiovascular risk factors, then they need to be doing, interval exercise, things like that. Saying that you're vacuuming every day and you're cooking and you're grocery shopping and stuff, that's a little activity. I'm not sure that I would call that much exercise as far as when we're talking about cardiovascular risk reduction.
Can you comment on bowel flora and obesity?
Oh, the bowel flora and obesity thing now. Bowel flora is really getting a lot of interest, and it's being related to everything, obesity, diabetes, all kinds of stuff. I think we have to wait and see what kind of sifts out, because when you think about it, a lot of people get antibiotics and that will sort of wipe out their bowel flora for one thing or another, and they don't suddenly become obese immediately thereafter. I think we're going to have to wait. It's sort of like when Helicobacter was discovered, and then suddenly, an infectious process for something that was thought to be due to stress, ulcers. So suddenly, people were looking for bacterial causes of everything. Bacterial causes for fibroids in the uterus, and bacterial causes and a lot of those things didn't pan out. So there may be some association with bowel flora, but it might be bowel flora differences might be because of what they eat, rather than causing them to be obese.
I understand to be a great proponent of metformin. What would be your minimum A1C and BMI for starting at?
Minimum A1C and BMI. Well, if they have insulin resistance, so if they have hypertension, high triglycerides, a large waist circumference, or any of those, or low HDLs, or obesity, I think I said, or diabetes. If they have those risk factors, then they don't have to have prediabetes. If they've got hypertension, obesity, and dyslipidemia, then I'll start them, because again, that's primordial prevention. If they've got impaired glucose tolerance or a fasting blood sugar of 100 or greater, I'll start them on it. And my dose for prevention is 2,000 milligrams a day. 2 grams a day. Yeah, I mean, because the dose response curve for metformin is like this. So if my elbow is 0, okay, so that's 0 metformin, and this is its activity, so to speak, its ability to improve insulin sensitivity, decrease insulin resistance. So at 500, you get this much effect. At 1,000, you get this much effect. At 1,500, you get this much effect. At 2,000, you get this much effect. So why not use the full dose that's going to give you the best effect? And that's even in a small person, as long as they've got good kidneys and they can tolerate it from a GI standpoint. And generic extended release metformins really vary. So they have to, maybe shop around to find an extended release metformin that works for them. I could tell you the name of a brand name one that's wonderful, but I don't want to get commercial. After 2,000, and in Europe we use up to 3,000. When I consult in Europe, they use up to 3,000. But the dose response curve does this. So when you're going from 2,000 to 2,550, which is the maximum allowed in the United States, to 3,000, that's the maximum allowed in Europe, you're not getting much more effect. You're just likely to get more side effects. So generally, 2,000 is the dose that I'm going to use in just about everybody.
Okay, I'll give you 10 seconds.
Oh, 10 seconds. Okay, 10 seconds. The Medical Society of the United States and Mexico is having their 62nd annual symposium in Ajijic, Mexico, which is a half-hour taxi or bus ride from Guadalajara, which has, there's really good connections nonstop from the United States to Guadalajara. So you don't have to change planes in Mexico. This is the 60-second one. It's October 21st to 25th. We're going to make flyers available to you. It's doctors from the United States, doctors from Mexico, and it's multi-specialty, so that, like, the neurosurgeon will tell you not how to do neurosurgery, but when to refer somebody with epilepsy who might respond to a neurosurgical technique, that sort of thing. So it's for a general audience, general medical audience, and so I invite you all to come. It's really nice.